Hello, this is Dr. David Wolinsky from Cleveland Clinic in Florida on behalf of Referring Wisely, talking to you about improving the value of cardiac imaging. Refer Wisely is a joint initiative of the American Society of Nuclear Cardiology and the American College of Physicians to provide education regarding the appropriate use of diagnostic imaging with a specific focus on the appropriate use of myocardial perfusion imaging. Let's start with an illustrative case. A 61-year-old male presented for routine stress testing. He was asymptomatic at the time. He subsequently underwent coronary angiography that led to PCI, and details are not available. Despite being asymptomatic, a year later he underwent coronary CTA and then repeat coronary angiography, which showed no significant stenosis. 1 year later, he was referred this time for SPECT MPI, which showed anterior wall ischemia, and a year later, he underwent repeat coronary angiography, which showed a totally occluded diagonal branch. This finding anatomically would have been consistent with the findings on the SPECT myocardial perfusion scan. 2 years later, he had a repeat SPECT myocardial perfusion scan that was unchanged from prior, and had been asymptomatic throughout. And he was told subsequently that he would need to undergo coronary bypass surgery soon because, quote, there were no more stents possible, quote. So 2 years later, he sought evaluation at another institution because he was looking about the availability of minimally invasive coronary bypass. He had no angina. He had no other vascular disease. He was active and exercised without any difficulty. He was maintained on low dose atorvastatin, aspirin, and clopidogrel. Now the patient says, do I need surgery yet? So on the next slide, let's look at the options of what tests should be done. These options include 1. Optimized medical therapy only. 2. SPECT myocardial perfusion imaging on medications. 3. SPECT myocardial perfusion imaging off medications. This might lead to a larger perfusion defect than one seen if the patient were studied on medications. 4. Coronary CTA. 5. Invasive angiography. Or 6. Other testing such as stress echo or stress CMR. So on the next slide, we see the 2013 multimodality appropriate use criterion for the detection and risk assessment of stable ischemic heart disease. This guideline helps many of us decide when and which tests might be appropriate to carry out in assessing our patients with stable ischemic heart disease. So if we look at the table on the next slide, table 2.5, looking at the asymptomatic patient, and looking at indication 70, greater than 2 years after PCI, we can see that exercise EKG may be indicated, stress radionuclide imaging, stress echocardiogram, and stress CMR may be appropriate, but coronary calcium scoring, coronary CTA, or invasive coronary angiography would rarely be indicated in this point of view. We need to discuss this topic a little bit more because there are no specific criterion for serial testing in these patients. That is, somebody who may have had a PCI in the past and maybe 2, 4, or 6 years beyond the original PCI, and they are asymptomatic throughout this entire period of time. We clearly can see that testing somebody for the first time 2 years after PCI may be reasonable, may be appropriate, but probably repetitive testing is of little value in the asymptomatic patient. So let's now look at our choices on the next slide. What tests should be done? And the answer here is optimal medical therapy only. He is asymptomatic. He has stable disease anatomically. He has stable disease physiologically. And he should be continued on optimal medical therapy. Interestingly enough, he's only on a very low dose of atorvastatin, and that dose should be continued. Aspirin should be continued, and one can consider discontinuing the clopidogrel. These decisions are not easy for the referring physician. Determining which tests to do and when to do them is increasing challenge to many of our referring doctors. So the American Board of Internal Medicine developed a program called Choosing Wisely. And Choosing Wisely helps through shared decision-making between the patient and the physician, deciding what the most appropriate tests are to do for a patient. Choosing Wisely aims to promote conversations between clinicians and patients by choosing tests that are supported by evidence, not duplicative of other tests or procedures that are already received, free from harm, or truly necessary. In other words, you make a decision to choose a test that's going to give you more information that you had ahead of time, that's unlikely to lead to high-risk procedures that would otherwise have not been indicated, and will help guide the therapy with more information that you would have had without the test. The next slide looks at the examples of choosing wisely that the American Society of Nuclear Cardiology submitted. Number 1, don't perform stress cardiac imaging or coronary angiography in patients without cardiac symptoms unless high-risk markers are present. Number 2, don't perform cardiac imaging for patients who are at low risk. Number 3, don't perform radionuclide imaging as part of routine follow-up in asymptomatic patients. Number 4, don't perform cardiac imaging as a preoperative assessment in patients scheduled to undergo low or intermediate risk non-cardiac surgery. And number 5, use methods to reduce radiation exposure in cardiac imaging whenever possible, including not performing tests when limited benefits are likely. So despite all these guidelines, recommendations, and appropriate use criterion, why do physicians continue to prescribe low-value care? And some of the examples here are seen on the next slide. There are concerns about malpractice. There's the concern to reduce uncertainty. The physician comfort level is just not adequate, that he doesn't need to do another test to become a little bit more assured that the patient is stable. Patient's insistent. They may come in and say, my insurance expires at the end of the month. I want all the tests done that I can have now, just to be safe and just to keep patients happy. So let's look a little bit more on the malpractice issue. And this is a paper that was published in 2017 from the Joint Commission, looking at the issue with missed cardiovascular diagnosis, a malpractice analysis. It is rare for a patient to present with very low global cardiovascular risk to have a missed cardiovascular diagnosis. That is a myocardial infarction that is missed upon presentation. Most of these people have at least one cardiac risk factor. Most of these patients are clinically misdiagnosed as opposed to having false cardiac testing. That is, the clinical suspicion may have been for one specific disease. Tests were ordered to work up that diagnosis, as opposed to a decision being made to not test at all. We need to reduce expensive testing in the lowest risk population. We need to employ testing with proven ability to be effectively diagnosing and risk stratifying patients with coronary artery disease. Once we've established the likelihood of the disease, then we need to determine what is the risk of a cardiac event. What is the time period of the risk? Is it 2 days? Is it 1 month? Is it 90 days? Is it 2 years? Different tests give different risk predictors. We need to determine which is the best test to do in a given clinical scenario. And most importantly, don't do a test if the result will not solidify your clinical decision making. So let's return to our patient, and 3 years later, now he returns. He's had no interval cardiac events, but he returns for evaluation now, stating that he has a decrease in his functional capacity. He's pre-op for extensive vascular surgery, and he now gets short of breath after walking 5 minutes. He has no angina. And now we're faced with the question, is testing appropriate? So we can return to the appropriate use criterion again, this time looking at Criterion 75. Patients with poor functional capacity undergoing vascular surgery with greater than one clinical risk factor. And in this setting, you can see that radionuclide imaging, myocardial perfusion imaging, is clearly indicated as appropriate. So the patient was referred for pharmacologic stress myocardial perfusion imaging. It was felt that his decrease in functional capacity and peripheral vascular disease would limit his ability to walk on the treadmill. So he underwent pharmacologic stress, and the images can be seen on the next slide. And as we move on to the subsequent slide where you can see arrows, there is a small, mild, reversible defect involving the anterior anteroapical walls that reverse. When you look at the bullseye plots, you can see similarly a small, mild, reversible anterior defect. This is considered a low-risk scan, consistent with single-vessel disease, and in fact consistent with what his prior angiogram had shown, that is a totally occluded diagonal branch, and what his prior myocardial perfusion scan that showed anterior ischemia. So very, very stable disease over several years period of time. Based on the above, the patient was felt to have a low-risk stress test, chronic stable coronary artery disease, and it was felt safe to proceed with surgery. This was carried out uneventfully and without cardiovascular complications. On the last slide, we'll sum up what we've talked about here. Cardiac testing must not only diagnose the presence or absence of disease, but also define cardiac risk. More importantly, the results of the test must define appropriate subsequent therapy. Testing asymptomatic patients is of declining value, even with known coronary artery disease. And physicians should think about what questions need to be answered before determining what test needs to be ordered. You need to think about, what does the patient want to know? What do you need to do to get him that information? Which tests help you achieve that? And what tests help you decide what tests need to be done? As Don Berwick said, in healthcare, innovation is hard, but dissemination is even harder. I thank you for your time. I would now like to introduce Dr. Gretchen Diemer from Jefferson University Medical School, who will discuss this case from an internal medicine point of view.
Hello, my name is Dr. Gretchen Diemer, and I'm an Associate Professor of Medicine in the Division of Hospital Medicine at Jefferson University in Philadelphia. I loved going through this case because, as Dr. Wolinsky points out, a lot of cardiac testing is done without regard for how it will help manage a patient's case. There are many contributing factors for this, as he describes, but I believe the search for certainty or the discomfort with uncertainty is a really big contributor. The fear of being wrong by doing nothing is far greater than the fear of being wrong by doing something. Physicians as a group have a pervasive fear of error and may feel that more testing is always the way to reduce that chance. The Choosing Wisely campaign and the appropriate use criteria tables for testing can be helpful in ensuring tests are chosen with value in mind. But a thoughtful formulation of the clinical question to be answered, combined with an understanding of the test's characteristics, is ultimately going to give the patient the most value out of any testing that is considered. These include the concepts of sensitivity, specificity, and positive or negative predictive value associated with specific tests. In a nutshell, if your pre-test probability is either very high or very low, even a test with the best characteristics is unlikely to change your post-test probability very much. Even our gold standard tests have false positives or negatives. Tests help the most with intermediate pretest probability, but even then will almost never provide 100% complete certainty. As Dr. Christine Lane wrote in her 2012 Annals of Internal Medicine article, there are several questions that a clinician should answer before proceeding with a test to ensure that it will bring value to and change the management of their patient. To paraphrase her, asking, what value could this test bring to my patient? and what do I expect the test to show, followed by if the results are different than I expect, how will I act upon them? I found these questions steer me away from tests if I can't see the way they will change what I'm doing, and they guide my discussion with my patients about using tests. Doing tests just to reassure a worried patient in the setting of a low clinical suspicion for a disease has been shown not to reassure them in the long run, and there are liability data that suggest that missing communication about tests that have been done or harm from tests that were unneeded are actually frequent triggers for malpractice. Most problems with misdiagnosis result from an incomplete or inappropriately interpreted history from the patient, not the lack of testing. With cardiac testing, many primary care physicians are comfortable with diagnosing coronary artery disease using myocardial imaging tests. But as I have gone through the referring wisely cases with these cardiologists, I have learned there are many subtleties in how these tests predict prognosis and likelihood of cardiac events rather than just diagnosing the presence or absence of coronary disease. The Referring Wisely case compendium can guide you through these complex decisions to help provide the highest care to your patients, and I encourage you to explore the other cases. Thanks.